but welcome everyone to this evening sessions. And the topic is around my health and happiness. My name is Mike Fulford, as Chris has said, and I'm one of the learning disability nurses in Wigan for Wrightington, Wigan and Lee, and I work in the community. Tonight I'm joined by Joanne Barrow and possibly her son Tom, and I supported Tom and his family a couple of years ago now as he moved through into adult services in a place where a lot of you are now, and so we felt that that would be really good to share their experience. We also have one of our wonderful GPs with us, Dr. Liam Hosey from the Dickinson Group Practice, and he's going to talk to us around things like annual health checks and some of the work that he's been doing and some of his experiences. So we'll go to Joanne in a couple of moments, but first I guess I just wanted to mention one of the reasons for what we're talking about, because there's many different reasons why those with a learning disability can face health inequalities. These can be things like health professionals having little or no awareness of the need for reasonable adjustments to their approach or the service that they're offering, or to the person with a learning disability, which can then lead to maybe a delay in providing healthcare. Maybe they don't recognise when a person is unwell or because of how they present, and the health professional may perhaps even lack confidence. Sometimes it's around training and education to make people more aware. It may also be because the individual has additional support needs to stay healthy, and without that support, particularly family and carers, the health might deteriorate. So although this stage in the young person's life and in your life can be a worrying time, hopefully with what we're going to be discussing tonight, as well as the information that you'll be able to access following the presentations, hopefully you'll have some of your questions answered, or at least know who to go to if you need more guidance. And so at this time, I'd like to hand over to Joanne to have a chat about her and Tom's experience. Thank you, Joanne.
Okay, thanks, Mike. So my son Tom is 25. He didn't want to stay on the Zoom call tonight because basically he's kind of not really interested in health and so on. So to him, preparing for adulthood and transition to adult services, I would say would just be about carrying on as he was before, avoiding going into hospital at kind of all costs, just carrying on doing what he likes to do and living life like a young person. So that was probably his aim, and that probably is where his interest in it begins and ends, really. So he's gone in another room and he's not appearing. So I'll just tell you a little bit about Tom. He's got really complex health needs. So he's got a tracheostomy, he's got a gastrostomy, and he has invasive ventilation overnight. So he has help with his breathing overnight through a ventilator. So as you can imagine, moving into adult services was a really kind of worrying time for us, because in paediatric services, I mean, he was the first young child that was on the caseload of the Children's Complex Needs Community Team. So, like, we remember what it was like before there was that team. So, from him being 3 to 8 years old, so he'd kind of have a nasogastric tube and whatnot. And it was just the general adult district nursing team. So it was incredibly difficult, really, because a complex child wasn't what they'd trained to look after, really, and it was a really difficult time. So when he was 8, the children's community team started out, and he was the first child on the caseload. So things really transformed for us then, because the team, they were so proactive, really. I mean, they would ring up and say, "Oh, should we stock you up on this? You need that." And they were fantastic at training Tom's PAs and carers, and they do the competencies and whatnot, and of the carers, to make sure they were up to date with all the latest advice. So they were amazing, and they were really holistic. So they kind of knew the whole family. They knew Tom's brother and sister and everything about us all, and it was It was like kind of being wrapped up in a blanket, I suppose, by then, because they were just fantastic, and they would liaise with all the specialist teams. They would liaise with a community paediatrician. So really, anything we needed, they were really, you know, fantastic to sort out. So we got that team. We got a nurse at Hope School. We had open access to consultants at the hospital, and so quite a lot of support around us. So as you can imagine, the thought of all that disappearing was really, really daunting. And then there were issues like, would I be able to stay with Tom in hospital? Because particularly with his communication, it would be just unthinkable really for him to be left alone there, you know, not be able to communicate with people. So there were all the concerns. And then things like really grey areas for us that people don't really seem to understand or know about, or it's difficult to get information about. And that is like, as you know, when your child's 18 and under, you've got parental responsibility for them, you know, all the medical teams and everything really kind of respect what you think and listen to what you say. And there's always that concern, will that alter when, you know, when the young person becomes an adult? And there's things like, you know, consenting to treatment and what that means, and all things around mental capacity. So all those were, you know, real concerns for us. So the concerns were, you know, who would replace the complex needs teams, because although equipment doesn't sound all that important, when you're technology dependent, it's incredibly important that you get the equipment, you know, in a timely fashion. And that was a massive concern to us. Like I say, whether we could stay in hospital and whether we'd still be as involved, you know, in decisions around Tom's healthcare. So I'm glad to say I've got a fairly positive story really about what happened, because what happened with us was Tom's primarily under the metabolic team at it was at the Children's Hospital at Manchester. And what we found was, well, what happened was, from him being 14 to 18, the adult consultant came to all the clinic appointments, so really got to know him. Similarly, the learning disability nurse did the same. So they got to know Tom and us, and we got to know them. So that was a really smooth transition. There's still all the support around being able to contact them whenever, you know, through, I email them regularly, and that's all worked out really successfully. On the last day that he was seen by the paediatric team at Manchester, we were there in the morning, then the afternoon we went over to see the adult team. So it wasn't just something that was done overnight, and it wasn't just hurried, it was really thought through. And as I said, that's just our experiences, but it certainly was a good experience. And then one of the things that the adult consultant said as soon as Tom moved into their services was he wanted to provide a best interest document, so that if Tom turned up in the middle of the night at the local hospital, people would know what to do and how to treat him. And they looked at various scenarios that may occur over the next 5 years. So things like, should Tom need urgent urgent blood tests and he was refusing, what would that, what did the people, well, Mike, you came to the meeting, didn't you, Mike? It was everyone involved in Tom's life really. And he wrote this, we wrote a 5-page document with a summary at the end, and it laid out all the various scenarios for Tom and what level of, you know, care it should be escalated to, and it's a really, really fantastic document. And luckily, whilst he's been in adult services, he's only had one hospital admission, and the hospital staff really encouraged us to stay. They didn't want us to leave, you know, that was very much our experience. It was, they wanted us to stay and they wanted us to be there all the time. So that just certainly wasn't an issue. And they you know, they said that the best interest document was absolutely fantastic, and you know, it helped them out so much. So we still do have access, you know, to specialists. I'd say, if anything, that we have Tom's under the ventilation team at Wythenshawe, and that's actually, it's not really replicated in children's services. So that's better, I'd say, than in paediatrics. So that's been great. I mean, the nursing side of it, we did have quite a few teething issues at the beginning because equipment was being ordered by the general district nurses, and it just wasn't really appropriate because Tom would be under Mike's team and they understand the complex care side, but then just a completely different team would then be ordering his equipment. So it just didn't work really, and they didn't really understand a lot of Tom's equipment and how important it was for him to have it, and they've got a big general caseload, and it just basically didn't work out. So that was the teething problem that the worst, most negative aspect, I think. But now, thankfully, it's moved over to Mike's team and everything's smooth running again. Everything's, you know, great. So that's good. So the other thing that we were advised going through, you know, preparing for adulthood with Tom is that the GP is really the only kind of person that kind of goes cradle to grave. It doesn't stop at, you know, children's, adults. And so that's why we were kind of really encouraged to go to Tom's annual health checks and things, which we have done, because I think it's important for him to be known by the GP and to be known locally. And very often the speciality teams will, you know, I'll discuss the problem and they will say, well, maybe this is something your GP could help with, or speak to your GP about this. So we have had quite a lot more interaction with the GP since Tom was in adult services, and that's worked out really well. They've been really supportive, and it's all been absolutely fine. I mean, he had a home visit quite recently to, you know, to sort a minor problem out, and yeah, it has been really it's been really positive. So I think I suppose my message is that it isn't, I don't think you need to be as worried as maybe you are. Or, speaking from my own experience, we didn't need to be as worried as we were, because, you know, Tom's as healthy and well, and is, even with all his, you know, quite complex health needs, he's avoided hospital. He's, like I say, he's just had one hospital admission since he's been in adult services. So I think my overall message would be that it has been a really positive transition for us. Is that 10 minutes, or I can talk all night? It's
No, that's good. That's good, Joanne. No, I think you've thank you so much for that. No, thank you. And like you say, I've had the privilege to work alongside and support you and Tom and the family through that stage and that sort of transition, if you like, into adult services. And
yeah,
and I think what I would say is as well, as scary as it was for you, it was also quite scary for me, because
I can well
feels
imagine,
like taking on that responsibility with Tom, with all of his various health needs, and realizing kind of, like, as you say, the fragility of it. You know, should we not have that equipment, if it's not there and he's not got it, potentially could end up going into hospital. But we've kind of managed to sort things. And
yeah, I think one of the paediatricians said we're as people are now going into adulthood with these much more complex interventions, it's up to the service really to move along with that. And I think probably Tom was your first, but then if you get another person with similar needs, you'll be fine.
Yeah, and I think as well, we'll probably come on to this a little bit when I do my bit, and just in terms of that information passing on, and that's really key, like you say, health documentation, that information, because sometimes people, even though we look to other health professionals and we see somebody with a title of a consultant, it still doesn't always mean that they know everything. They can be very specialist in their area. And my experience is that other health professionals will value that information or those details, or speaking to family or carers who know that person well. They might not always have the answers, but they'd certainly value that information. So that communication is so key.
No, you're absolutely right, and I've not found any change in that moving from children's travel services. It's been exactly the same. Yeah.
Yeah, lovely.
Okay,
Well, thank you, Joanne.
Thanks.
You can go and rescue Tom now. But yeah, so thank you for that. So we're going to hand over now to our next speaker, Dr. Liam Hosey. Thank you for joining us this evening.
Thank you so much, Mike, and just absolutely amazing to say thank you so much for the opportunity to be here this evening. And I feel suitably nervous trying to follow on from Joanne's, I think, rather from the heart sort of description of your lived experiences, Joanne. And I think just by means of introduction for myself, I'm a local GP, so I'm in my practice in Wigan Town Centre. I've been a GP for 17 years. As the slide says there, I've got this very grand title within the CCG of Integrated Neighbourhood Service Clinical Lead, which makes me sound really, really important, and I'm not important at all. It's just an amalgamation, if you like, of a few roles that I've had. So over the years, I've had the pleasure of working with Mike and his team with some areas around sort of cancer screening and also some stuff around end-of-life care, because that's where sort of one of my sort of key passions was, and this has sort of evolved a little bit into a bit of a role that I do. So my sort of brief was today was just talk a little bit about general practice in primary care and how we may get the best out of it. And certainly, I think maybe a few little tips, maybe, but an acknowledgement that the system isn't perfect, and maybe that's sort of part of what we're here tonight to sort of maybe discuss how we can sort of challenge that a little bit as well. So hopefully Amanda might be able to do a bit of a next slide for me, if that's all right, Amanda. So yeah, just a few sort of points that I genuinely would like to cover, and I think Joanne touched on a little bit about sort of health checks and annual health checks as well. We'll touch a little bit about on that as well, and maybe if people don't want to sort of engage in that process as well, what that may mean, which isn't a problem. It's just how we sort of can plod through that if needed to. So next slide, Amanda. So first of all, a bit of a sort of a few sort of technical terms in a way, and most of us, I think, will probably have some idea of general practice. So I hope most of us are on the call are registered with GPs and have some interaction with GPs. So I'm a GP. Primary care is a bit wider than that. So we often hear those terms knocked about a little bit, and primary care sort of, I think, probably in a nutshell, is anything that isn't secondary care, i.e. hospital care. So that's things like our dentist, our optometrists or opticians, our community pharmacists, podiatrists, so people look at feet, some of the community nurses, but in whatever guise they are. So it's a sort of this huge sort of system that sort of sits out there, sort of outside those hospital walls. And clearly it's not my remit to talk about now, but I think one of the challenges is how we get sort of our colleagues in the hospital to sort of interact better, with those sort of community services as well. Now, as for GPs, there's lots of GPs across the borough. I might get this wrong, so please don't pull me up here, but I think there's currently 57 practices in the Wigan borough. It has slimmed down ever so slightly because over the years a few practices have sort of joined up together. Now, the way those practices work, they tend to work on sort of geographical footprint. So you have to live within the practice area. Each practice has their own area, and it is sort of often based on streets or areas or sort of postcodes, if you like, or however someone has decided they want to sort of draw that boundary. And that sometimes can bring a little problem, I think, to families if people move out of that area, and often that can be a real challenge if someone gets to know the GP really well. Let's say and lives in the central Wigan and registered with me, for example, then moved to Leigh, then that would mean to find another GP in Leigh because it's way out of our area. So that can be a challenge as people move around a little bit. With having 57 different practices, unfortunately, there can be 57 different ways of doing things, and I think that really can be a problem. So there's a slight lack of uniform access, I think, across the patch. So there's a mixture of computer systems, there's a mixture of phone systems, and how people access that surgery. One of the things we will talk about a bit is how to sort of get to know your surgery and get to know what the best way of perhaps doing that is. Also, one thing I will say is that GPs are there in one way, shape or form 24/7. So there is a service. So when we're shut, so our normal hours are sort of 8 in the morning till 6:30 at night. but there are out-of-hours GP services in one way, shape or form that sort of cover those hours outside of what we call core general practice hours. There's also something called extended access, which doing this sort of talk in COVID times is a tiny more challenging because some of those services have been modified a little bit, but we do have sort of surgeries across the borough where people can book into and see a GP, where it's not your own GP, but they do have access to your sort of medical records. So that is that service that's available there as well. So this is another sort of option open to us. So next slide, please, Amanda. So one thing I will say is just I think to sort of acknowledge here that I think the last sort of 6-12 months have been sort of very difficult, I think, for all of us, and I mean all of us in a sort of a population setting. And I think, you know, without doubt, there's been some people will describe at some times difficulty accessing GPs and their care they provide. Very much we have been open to give face-to-face care, but perhaps not in quite the traditional way that people used to book appointments. So maybe people booked appointments years ago by ringing up reception, say, I'd like to see a GP. When do you want to come in? And you get a slot booked in. And perhaps because of COVID, we twist that around a little bit now. And what we try and do is sort of what we call triage people a little bit more. So try and find out exactly what the problem is so we can make the best sort of shared plan available, which often is a face-to-face appointment if needed, but it may be a bit of phone access, it may be sending a photo and working out from there. So the method of accessing us has changed a little bit, but we are still there. I think many of us may have been becoming more accustomed to a system called Ask My GP, that is a sort of web-based portal system that people sort of put queries into. Now, basically, it's something that helps streamline workload at our end as GPs, but if people don't want to use it or can't use it, and there's many reasons behind that, people can still phone the surgery, and that information will be put onto the Ask My GP system. It's just a way of the GPs perhaps having a workflow system, if you like, so we have sort of a list of people that we can ring up. Equally, the way we generate prescriptions has changed an awful lot. So maybe many of us years ago used to go and pick up a prescription or physically pick up that green piece of paper. And over the years, we've changed that now, and most of our prescriptions are sent electronically to a pharmacy. Again, that's probably a key learning point here as well, that we need to get a pharmacy that we're comfortable with. That might be the pharmacist that's close to your home. It may be the pharmacy that delivers medications. Okay, it depends what our needs are. Some people use online pharmacies, so there's some pharmacies that the prescription gets sent off to a sort of very remote location, and then that gets delivered through the post to you or dropped off. And I guess that's knowing that familiarity of, you know, what your local pharmacy can offer versus what sort of an online pharmacy can offer, and making sure you're comfortable with that. The GPs, we also try and sort of discriminate a little bit, if you like, or differentiate is probably a better phrase, of sort of routine care versus urgent care. So if people really do need sort of urgent on-the-day care, we can provide that. But routine care is possibly a bit more planned. So look, I need to come in on Tuesday because that's when my mum's off, and we can work around that and we can plan that, and that gives us a bit more sort of, I think, ability to sort of be a bit more sort of organised, if you like. But if someone's got an acute problem, that often is, maybe not the GP you know regularly, it might be the GP that's on call that day. So I've been our duty doctor in surgery today, so I've seen all comers and tried to do with all things. And sometimes that might mean that I don't know the person brilliantly, but I do have their records. Practice nurse appointments, which we'll come on to in a time or two, a slide or two's time, they routinely tend to be more pre-booked, so they tend to be more pre-planned in a way, and that can again sort of mean that things are a bit more organised in a way. And again, nurses tend to work at slightly longer sort of appointment slots than some GPs would do. But again, that is something we can talk about, how we may want to challenge back to the surgery if we need to around that. So next slide, please, Amanda. Now, just moving on a little bit, and I think Joanne sort of touched a little bit, and Mike did, about sort of annual health checks. So there is really a sort of a local and a national aim to sort of offer all people who are on the Practice Learning Disability Register over the age of 14 an annual health check. And that's usually with the practice nurse. I say usually, it's perhaps almost always with the practice nurse, I have to say. That is one way, I think, of starting to try and implement that transition period, because very much this would have been something of the health checks that were done potentially by the hospital and the sort of consultant paediatricians and their associated teams. This is how people start to try to move into that sort of adulthood phase, if you like. Practice nurses would tend to would develop a health action plan, I think, with the individual as well, and cover multiple areas within that. And that is a bit sort of bespoke in a way. So if people have got certain health needs, they will try and pick up a little bit on that. But there will be areas sort of that are touched on, such as smoking, alcohol intake, maybe depending on age, height and weight. So looking at those if necessary. There's also some other bits of screening there. So depending on the age of the person, which may not be as relevant sort of when we're 14 or 15, but more relevant the older we get, things like cervical smears and how we may access those. And the older we get, things like breast and bowel screening as well. And that's much more sort of age 40, 50, 60. So, much further in the future. But it's something that will get sort of picked up. And what we know in general is that people who have been sort of diagnosed with learning disability definitely seems to do worse in sort of health outcomes in the longer term. So we recognise that if we have annual health checks, we can maybe pick up things like, somebody's blood pressure might be a bit high, maybe the cholesterol levels, we can check the sugar levels, etc. And we pick up problems before they become a real problem. So that's one of the purposes of the health check. What I would say at this point, though, it's not an absolute must. So no one's going to shout at someone if they don't want an annual health check. And that is something to work with in your surgery. And you absolutely, as a sort of family unit or as a carer unit and an individual, say, look, that's not something for me at the moment. And no one's going to sort of twist someone's arm and say, that's really bad, you're not doing that. But you will be offered it. Okay, so it's something that it's something that we're offered year on year. So if we can do next slide, if we can. Now, what I would say is, how do we make the most of the appointments? And absolutely, I will say that primary care is not perfect, and we don't get it right. And I think Mike and John have both touched on this a little bit, that this is sometimes about the sort of education for us as health professionals. Okay, I am no expert, and feedback is an absolute gift. So if someone says, look, I really need to come sort of at the start of the day or the end of the day, or have a waiting room that's not crowded, we need to know about that as a practice and work around that. So if it's specific times that people come in, practices will work around that where they can. Okay, clearly if it's an emergency need, that's a bit different, but most of the time we can plan these things a little bit. Absolutely, people come to appointments. So I know Joanne talked a bit about staying in hospitals, but we get a little bit of anxiety at times from family members. Oh, can I come in the room? And absolutely, of course you can. And we can work around that. Often as a GP, it's really good to sort of know what we're going to deal with today. And that's how the Ask My GP system works. I know we've put something in the chat there, which is really quite useful. Equally, what I would say is be realistic. So if we have a list of sort of 25 or 30 problems, you've got to think, crikey, what do I do with that? But actually, if we have a list and say, right, let's try and work through that, and we may do that over a course of a few appointments, that's entirely appropriate. And some GPs, we're only human. We think, crikey, what can we deal with today? But actually, if we can prioritise that a little bit, sometimes it really helps work out what is the sort of, the burning issue today. What can we put on the back burner for a little bit, but then work through sort of over the next time. So that can help us, I think. And the last thing I would say, I guess, is our practice nurse team. They're a magnificent sort of point of contact. And I think Mike and his team work very, very closely, I think, with local practice nurses to try and sort of problem solve it a little bit. So maybe sort of get to know your practice nurse and getting comfortable with them is a really nice sort of thing to do as well. And they tend to sort of really want to sort of, be helpful, clearly patient-centred like we all should be, but actually try and problem solve a little bit rather than sort of see the problems and not sort of want to address them. So if we could do the next slide if possible. So I think I'm just about running out of time. I don't want to sort of detract from Mike and his bit. What I would say, just to all of us, is become familiar with your GP surgery. We all do it slightly differently, but some of us may have been registered for that surgery for a long, long time and get to know what works for them. And if it's a way of accessing appointments that works for you, use that. Try and embrace the technology that's open to us. Okay, we're all, perhaps getting a bit more used to sort of living in this virtual world over the last 18 months or so. Sometimes we can do some really good, quick things like sending a photo of a skin rash might mean we can prescribe over the phone or prescribe by that photo, and that can be really, really good because it means you don't have to drag yourself out, etc. But equally, if it's the technology isn't working, acknowledge that to the surgeon. Say, look, I can't do that today. I really need to speak to someone with a view of coming in, and the surgery will work around that for you. Be absolutely open and feedback. People need that feedback, okay? And if they say, look, this isn't working, the surgery can take that away and reflect on it with their practice team and their practice manager. Okay, so I think we've moved away, I hope, from that sort of era where doctors know best and we never listen to anybody. I'm not saying it's perfect, but it's absolutely the sort of thing that if people give that feedback to say, look, can we do this a bit differently, we really should be listening to people for that. I'm really conscious now that I don't want to distract anymore from Mike, so I think that's the end of my presentation, but I'm sure we can take some questions at the end, Mike, but just say thank you so much for people listening. Again, hopefully I can clarify things as we go on as the evening progresses. So thank you, Mike.
Thank you, Liam. You're actually well ahead of time, so we're doing okay. I feel like I'm going to fill the gap now, but thank you for that. No, I think it's good, and I think as we go through and with the questions, there'll be some things that we draw together, and like again with what Joanne fed back as well. So I'm thinking Amanda will be should be like little Wallace and Gromit in the background, putting the slides up and doing all the technical bits. But my bit was really that I thought what I would do is, there we go, thank you, Amanda, is just to talk about the Community Learning Disability team. So as I said, we're part of Wrightington, Wigan and Leigh, part of the NHS within Wigan. Not everybody comes to us. Obviously, we're talking about people who have a health need either support around specific areas of health. It may be just short-term interventions. It may be longer term, like with Tom, we're involved in the background there around visit equipment and other stuff. But some people might just be a short bit of work, you know, that like we're talking with Liam, that you know, accessing the GP surgery for a health check, and that might be really frustrating or makes somebody very nervous. They might not want to go, or just for a blood test. So we might be able to work just that short bit of time with them. So go to the next slide, please. So this slide really just to show who is involved within our team, multidisciplinary team there. All of those services are within the learning disability team, made up of various sort of specialities. And as I said, it may be that it's a combination of a few people, or it could just be linking in with one or another service. Next slide, please. Oh, it was a bit fancy, wasn't it? Disappearing. There we go. Thank you. So in terms of working with young people, so for us, it's where people get identified by the local authorities having specific educational and health needs. And so around 14 years of age, we will start doing some planning. And also it might be some work around supporting people with challenging behaviour, autism, forensic needs, and that can commence around the age of about 16. What tends to happen is we because we've been working in the service and the system for quite a while, we'll get that information through in a really timely manner. So we will be made aware of people early on, you know, 14 years of age, who will be coming up for moving on into adulthood over the next few years. So our sort of work and intervention might be very limited at the start. We just need that awareness to think, right, we need to come back to them within, you know, 12 months before they leave. What do we need to start thinking about and planning? So that's really when we would be sort of getting involved with them. And but we're, you know, in the background, everybody's sort of speaking to say, we've got these young people, we think your team may be wanting to get involved when the time is right for them. Okay, next slide, please. So I often feel like we're having an eye test. I'm not going to read every single bit of every single slide, but it's just to sort of show some of the different things that as a service that we can provide and support around. So I'll just pick out a couple. So the top left one, we've got improving independence and mobility. So as you've seen, we've got within our service some occupational therapists and physiotherapists. And we also have assistant practitioners and support workers as well. So they may look around tasks around whether it's around mobility, perhaps linking in with moving and handling, or whether it's the wheelchair service or other places like that, but also looking at other tasks. You know, the OTs might do things like travel training, or helping people to make a meal or a drink or things like that, looking at equipment that they've got in the house. We've got speech and language therapists on there. So in the middle, we've at the top improving communication, and then also around eating and drinking difficulties. And again, that's a lot of people think of speech therapists around just communication, but from my experience, it's also around safe eating and drinking, looking at different textures and how to support people, how to keep them safe, trying to avoid things like choking episodes and things like that. On the top right, specialist nursing assessments. So we sort of touched a little bit on that and overlapping a bit with what Liam's talked about in terms of health assessments and health checks and health action plans. And so things do overlap a little bit, and probably over time, you know, we may come up with one great document that we all use and streamline things even more. But at least that information is being captured somewhere, and again, we can share that if and when needed at hospitals, or you know, when people go for other assessments and things like that. Towards the right, down in the middle on the right, facilitating pathways in acute hospitals, primary care, mental health services. So again, we touched on it a little bit, but over the years we've sort of developed links with various services, and those links will continue as new services are developed and opened. But also links with other hospital sites as well, like Joanne's mentioned, you know, Wythenshawe and Manchester and Salford Royal, for example, Bolton, and obviously because we're borough-wide, the borough, Wigan Borough is such a massive borough, and I have patients who may go to hospital who live over at Tilsley, who might end up going to Bolton, and Bolton have a couple of really good hospital learning disability nurses. So we've got those links there for those times if we need to communicate. Also things like, you know, as we've said in the middle bit there, access to adult services from education, linking in with those services and trying to make things go as smoothly as possible. And as Liam said, things, you know, sometimes don't run as smoothly as we would like them to do, but the main thing is that we're there around people, a bit like a safety net, just trying to move things through as smoothly as we can, acknowledging all of those worries and things that, you know, anxieties that people have at this time. Really important to acknowledge that. And myself involved down at the bottom there, where we've got complex physical health needs, going back to some of the things that Joanna's mentioned. And part of my role within that is looking at training. So, you know, Joanne's mentioned things like PEG training, and so we can develop some of those skills and train people, support people to learn new tasks and developing perhaps some of the skills that maybe they didn't have before. And there's lots of services now we link in with, day services, respite, that all are now able to support a lot of the people within our team and our service. So next slide, please, Amanda. So, as it says there, our aim is to work with patients to effect a reduction in health inequalities and behaviour, and it's something that is a big area within learning disabilities, hopefully to promote independence in all aspects of daily living. Although we acknowledge that people will need support, but to have that sense of independence, that sense of achievement, is something that's really key. And so we'll do things like assessments, and like I've touched on with the various people who work in our service, but also looking at how we provide those assessments when it's convenient. Where do we provide those assessments? Not everybody likes having somebody come around with a clipboard and gather lots of information. So look at how we deliver that, how we acquire that information through conversations, maybe not always in the person's face and putting them off, you know, looking at what's more appropriate and where they feel comfortable at that time, so that we gather the right information, the true picture that will then inform everybody else who's around them. And also making sure if there are other people involved that we coordinate some of that information. There's nothing worse than having 5 different professionals come in, ask you 5 times the same questions, and then that information goes out in 5 different formats. Are there ways that we can maybe bring all of that together, work together, and share that information and make it less painful, if you like? Okay, next slide, please. So just briefly, just to touch on some of the different areas and people that we work alongside. You know, as we've said, different levels and different areas within the health service, but local authority certainly, and there's a lot within that, and a lot of other agencies that come out from within that, you know, like whether it's community equipment stores or the wheelchair service or other places like that, but other areas as well. But importantly as well, if not central, is coming back to yourselves, to patients, to families, to carers, to those people who know that individual well, to that individual first and foremost, but where there may be perhaps difficulties with communication or capacity or things like that, that we make sure that we've got all that true information, and that we share that where people are happy to share that information. I'm not saying we would just share absolutely everything, but we share that essential information to make sure that there is that smooth transition, and that services who are supporting that individual really do work together. Next slide, please. So I've kind of touched on this one just to say, in terms of what we do and when we do it, looking at when's convenient for yourself, whether it's coming to your home or, and obviously in this time of the COVID, it's where people feel comfortable as well. And we are mainly based in the community, and 9 to 5 or 8 till 6, it depends. We've got that flexibility. We're not an emergency service, but there are lots of services out there that we can tap into and link in with, should there be other things, whether it is district nurses or other out of hours services. We can make sure that people are aware should their involvement be needed, really. Okay, but the learning disability service is sort of based in Wigan. We've got a base in Pemberton, Plattbridge and Leigh, and so the team is sort of split between those 3 areas. So each of us cover a certain area across Wigan. Okay, next slide, please. So once we've got a referral in, so a referral can come from anywhere or anyone. It could be a direct referral from a person who says, I really feel I need that support, but it could be from a GP, could be from a social worker, could be from somebody within education, anybody really. And then we just put that, generally goes through a bit of a referrals meeting, and we would then work out, identify who would be best placed to go and meet that individual and see what support is needed, and work out what we need to do. Like I said at the start, depending on what the intervention is, whether it's long-term, needing care support, training for lots of people, or is it just that we really need to get a blood test because they've not had one for 5 years, how do we work with that? It may just be a short-term piece of work, and referrals do come back in. We might not keep somebody long-term, but they may come back to us as well. It can sometimes just be around signposting on. Sometimes, as some of you will know and feel, this time feels a bit like, a bit lost in the jungle sort of thing. You're not quite sure, where am I going? Who do I speak to? What do I do? Sometimes, we would come along and just help to signpost. And that might be all that's needed. You're a little bit lost. Who do I speak to? I'm not sure. And we'll hopefully direct you and give you that support as well. Okay, next slide, please. So I'm conscious of time. We sort of are ahead of time, but I've only got 1 slide on this, but I've just got a little bit written down here, and I hope people won't mind if I sort of read through it. One of the biggest comments, and Joanne touched on it at the start, was around that sort of capacity and best interest and decisions, and if somebody needs something doing, am I still allowed to say something as a family member? Am I still allowed to have a say? I'm really not sure. I'm very worried. So we've got set things in place that sort of really do guide us, and my experience is that these things work extremely well. They work well to get to work towards an outcome, but they also look to protect and support an individual who may at other times be perhaps at risk or very vulnerable, particularly if they haven't got family or somebody who knows them well. So a couple of things. We've got the Equality Act 2010. That's the framework around discrimination law, protecting individuals from unfair treatment and promoting a fair and more equal society. And we must avoid unlawful discrimination. We know that discrimination can happen, but part of my role, Liam's role, is to work towards, breaking down those barriers, making sure that people access So we have make reasonable adjustments, as Liam has mentioned, how we provide services, when we provide them, how we communicate with people. The Mental Capacity Act of 2005 is kind of the big thing, really, and it's that legal framework for acting and making decisions on behalf of individuals who lack the mental capacity to make particular decisions for themselves. Everyone working with an adult or for an adult who may lack capacity to make specific decisions for themselves needs to be aware of that and behave in accordance with the Act. So in terms of the Mental Capacity Act, it's designed to protect and empower people who, as I said, lack that capacity to make their own decisions. It applies to people who are age 16 or over. It covers decisions about day-to-day things like what to wear, what to buy from the shop, but also serious life-changing decisions, whether things like having a major operation. Examples of people who lack capacity, as stated in the Act, are things like dementia, severe learning disability, brain injury, mental health illness, a stroke, other things like that. Just because a person has one of those health conditions doesn't mean that they lack the capacity to make a specific decision. That's really important, because you have to think about what is the decision that we want to make at this moment in time. So someone can lack capacity to make some decisions. It might be to do with complex financial issues, like say a big operation, something like that. But they still have capacity to make decisions about other things, what they'd like to wear that day, what they'd like to buy from the shop, what television programme that they would like to watch. So the Mental Capacity Act states that we should assume a person has the capacity to make a decision for themselves unless it's proved otherwise, and wherever possible, we should help people make decisions. So that's support from family, carers, whoever it might be. And we shouldn't treat the person as lacking capacity to make a decision just because they make an unwise decision, because we can all make unwise decisions. We all do those things that perhaps we shouldn't do. It doesn't mean that we lack capacity. And if you make a decision for someone who doesn't have capacity, it must be in their best interest. So in terms of capacity, what they would normally do is they would do a two-stage capacity test. And again, this can be done. It doesn't have to be in a great big multidisciplinary meeting. It could be within the GP surgery. We're deciding to do this. Let's have a discussion about it. That can be your best interest meeting. So we're thinking about, does the person have an impairment? Maybe it's their learning disability. And does the impairment mean the person is unable to make a specific decision when they need to? Okay. So where appropriate, people should be allowed the time to make the decision. Do we need to answer this right now, or is it something that we need to do, but we've got some time to think about it and plan? And then we can look at how we put that information across. The Mental Capacity Act says that a person is unable to make a decision if they can't understand the information relevant to the decision, if they can't retain the information, and if they can't use it to weigh up the information as part of the process of making the decision. So often what they'll do is people will ask questions and then come back to it later to see if that person has remembered and taken on board that information. Before deciding that the person lacks capacity, it's important to take some steps to enable them to try to make the decision for themselves. So is there any other relevant information? A health assessment, a health action plan, a hospital passport, maybe. Can they be given any other alternative information? It's nothing worse sometimes than you get all that a legal pack, or you get something, and how often do you read every single detail? It's quite overwhelming. Are there any other ways of putting that information across? Can we present it in another way? Maybe it's around communication and how that person communicates and how they take on that information. Maybe a family member, somebody they trust, a close friend, might be able to help them with that information and that decision. Maybe it's about where you have that discussion. If you're sat in the middle of no offence, Liam, if you're sat in the middle of the GP's surgery, for some people that might be quite a scary place, with a consultant. But if you sat at home and you've got that time to make that decision, that might be more conducive. Is it in the best interest? If someone lacks capacity to make the decision and the decision needs to be made for them, the Mental Capacity Act states that the decision must be made in their best interest. So really what it's saying is that we need to kind of encourage those discussions with that individual, but we need to be aware of how we put that information across if we need to change it, but acknowledging that, you know, sometimes we have to make that decision. Sometimes it's very difficult, it's very complex, sometimes things aren't always agreed. You know, there's sometimes a lot going on, and it's quite a scary thing at times. And though, you know, if 2 or 3 people have got different points of view and opinions, the important thing is that all of that information relating to that specific decision is discussed within that environment, and people are then allowed to have those discussions around it and give that person time to come to that decision if they're able to do that. Okay, so mental capacity and best interest are some of the key areas of how we within the Learning Disabilities Service operate to ensure individuals are protected and receive fair and equitable treatment. We're trying to fight people's corner within that service. Right, sorry, I'll just take a deep breath there. So next slide, please. It's my final slide, you'll be glad to know. Okay, so as I put there, transition at any time in life can feel like a step into the unknown, or it can even feel like you're falling off the edge of a cliff. So as the service, we would aim to support and guide you through this time, linking in with services that you need and being alongside you as you step into uncharted territory of the adult world. And like we said, you can have your health services, as Joanne's touched on. We have a consultant and children's team, and you've got all of that there. And sometimes going out into the great unknown, you're thinking which services are going to get involved. And so our role, if we're involved and working alongside you, is to try and help you with that and guide you to the right people and get you that support. So there we go. I'm going to have a drink. So thank you. We want to come back on the screen, and then I think we're going to have just go through any questions or anything like that. I can see people are still on the screen, so that's reassuring.
Brilliant. Thank you very much, Mike. That was great. Cheers. I'm just going to spotlight our 3 speakers and just want to say sort of thanks very much. It was really informative. Lots of information for people there, and you know, I definitely think even the recording, it'd be great for people to watch back and take clips out of each one. Definitely, you know, like personal experiences from you, Joanne, really valuable. And Liam, Dr. Liam Horsey, you know, great stuff around annual health checks, and Mike, lots of useful information there as well, so that's brilliant. So we have got some questions that have been asked in advance that we can put to the panel. I think some of the questions that we had in advance have been answered within the presentations. So if anyone does have any additional questions they'd like to ask, I know we spoke about it tonight, you can ask in the chat. We haven't had any as yet. I think I can see a few people typing, so we may be getting a few coming through. A first question I'd like to ask is, if a person wants an annual health check or wants a vaccination, but they've got anxieties or a reason that they would find going into a GP surgery difficult, is there an option to have a check or a vaccination within your own home or an environment that you are more comfortable in? And that's to any of the panel. Yeah.
Do you want me to answer that first, Mike? I mean, absolutely. I think, you know, that's absolutely something that GPs and the practice nurse teams would work through. That, you know, there's plenty of times, plenty, but there's enough times where our practice nurses have done that, and that's across a whole sort of gamut of individuals, you know, to help out their situation. So I think absolutely it's something to discuss. You know, it's not a blanket, no, we're not doing that. It's actually, how can we help make that the best use out of, you know, surgery as a resource, and you as someone who needs our help. So it's absolutely it's something to flag and discuss and solve, really.
Yeah, that's great, really. That, and as my experience is, some of my patients who, for that very reason, have had said the practice nurse come to the house or the GP come to the house to do something. Sometimes it's just about having those conversations. The GP might not be aware. There may be only 1 or 2 people with a learning disability on their caseload, and maybe they don't have a lot of contact regularly. And so just having those conversations and explaining that would be the first start of that. Yeah.
Brilliant, thanks, Mike. The next question is, once a young person, I'll move on to the next one because that touches on mental capacity, and I think you've gone into quite a bit of detail there, Mike, around mental capacity.
So I have to do all those slides again, please, Chris.
Yeah. So this would be for young people who's coming towards 18 and they no longer have a general paediatrician to contact with any queries or concerns. What replaces that service, or where should they go with those sort of general concerns?
I can see Liam's typing, so I'll try and answer that a little bit. In that, what we find is it depends on what the particular health need is at that point where they're going into adult services. From my experience, sometimes the paediatrician sort of encompasses lots of the person's health needs. So what we do, what it's usually around, is identifying what are the particular health needs, what are the concerns, referring on into the correct services within the adult world. Whichever health professional service consultant is needed, and that would go on for that. So they would get referred on basically into that. So they wouldn't, they could end up with 2 or 3 health professionals and consultants out there, rather than just the one that they go to each time. But it usually does work well because those services are then more specific to that particular health need. Liam, I know you're going off there. I'm just seeing that. Oh, he's gone. He's gone. I've just seen that question about the COVID jobs. I don't know whether you'd be able to answer that before, because I'm not too sure.
No, absolutely. Thanks, Tyler. I was going to try and answer that. Yes, so I think, Tyler, without knowing absolute specifics, I think it's probably more about the medical vulnerability bit there, and it's rather than the age stuff. It's probably the condition that's triggering the 2 vaccines rather than the age. But it's something I would want to just go and double check myself, in all fairness, because I have to say with COVID vaccines, it's become quite confusing, I think, with sort of ever shifting guidelines. But I think it's the condition, Tyler, rather than the age, if you like, that's triggering that. But certainly, please check with your practice nurse, who will actually have access to notes and the most up-to-date guidance. I think that would be the ideal way of doing that, I think.
Well, that's great.
Thanks, Liam.
Thank you very much.
Right, he's off. Thank you, Liam.
Yeah, thank you. We've got a final question. I think maybe Mike, this should be one for you to answer, but maybe Joanne, you might be able to give some sort of practical advice of things that you've tried as well. So we've got someone who's wrote in who has autism, but I suppose this could go for sort of anyone who's scared about going into hospital. And what support is there to help someone who's feeling scared about going into hospital?
Yeah. Well, Joanne rightly touched on that earlier about going in to support Tom at those times. So my experience is that somebody who's very vulnerable, has health needs, something that's specific, whether it, and again, going over to autism, anything like you say, Chris, if that person has needs and they have support needs, then they're allowed to go in with that individual to the hospital. I touched on Bolton. Bolton have 2 learning disability hospital liaison nurses. We did have hospital liaison nurse, but kind of it's disseminated now into our team, so our complex care team. So we link in with the hospital. Hospital know our number. The safeguarding team up at Wigan are very good, not just for safeguarding issues, but identifying those people who maybe have additional needs, and they'll contact us. But yeah, you should be able to have somebody with you to support you.
Brilliant. Is there anything you want to add to that, Joanne, or is that pretty much what you just said?
Yeah, I think so. And like I say, we've only had one experience of going into hospital in an adult setting, and the staff couldn't have been better with my son. They were just really supportive, and yeah, I was really pleasantly surprised. Actually, they were really good. Yeah. But then again, obviously staying with him and having someone that he knows and whatnot is a massive help as well. But yeah, the staff were very supportive.
I think that's reflected in the staff. I think the staff are often very grateful because perhaps they're not sure, and definitely.
Yeah, definitely, yeah.
Fantastic. Cheers, both of you. That's really brilliant. So that's all of our questions for this evening, and we hope that everyone who's come along has really enjoyed it. So obviously you probably will be aware that the event is running all week. So tomorrow is My Independence evening, and that's going to be discussing a lot around independent living options for disabled young adults. We've got Lindy Wardle speaking, and she's the head of that sort of service. So she's going to be talking about supported living providers and the ethical framework. We've got Linda Ashcroft, who's a parent of a young disabled person who's recently moved into independent living, so kind of giving that sort of personal experience similar to what Joanne's done this evening. We've got an occupational therapist coming along to speak about property adaptations and different things like that. And we've also got one of the providers who's on Wigan's ethical framework coming to just speak a bit about their supported living service and how that works. So if any of you are interested in that type of thing, please come along tomorrow evening at the same time between 6:30 and 7:30 and join us, for another informative session. If you can't make it, as ever, we will be recording it and uploading it to Wigan Council's website at a later date so you can watch it back. Obviously, this session will be uploaded as well, so if you want to listen to anything back, or there's parts of tonight that you think, oh, that'll be really useful, but you want to listen back maybe in 12 months' time, you will be able to do so. The last ask from me is just in the chat. You'll see that Amanda Thomas has just posted a link to a very short feedback form that consists of sort of 2-3 questions. If you could take a moment to fill that out, it will literally take 1 minute to do. We'd really appreciate it. It just helps us make sure that we can improve for next time. So yeah, if you do get a chance, that'd be fantastic. But that's it from us tonight. So just another big thank you to Mike, to Joanne, to Liam for coming along and sharing all that vital information with us. And we hope to see you again later in the week. Cheers, everyone.
Thank you.